everyone, and welcome to the Texas Epidemic Public Health Institute Infection Prevention and Control Series 210 Quality Improvement. This lecture will briefly introduce how to select a quality improvement project at your specific organization, how to collaborate across different departments on quality improvement projects, and how to establish effective key performance indicators or KPIs to enhance infection prevention and control. This lecture will be recorded and you will be given access to the slides about 1 week after the lecture. So within a week, you should receive an email with a link to today's recording along with the slide deck for your reference. After we're done with today's lecture, then we'll briefly walk through a case example of how to develop, implement, and evaluate a quality improvement project in the learning activity. And then we will open it up for questions and answers after that time and just more discussion from the group. And then lastly, at the end of the lecture, we will ask everyone that has attended to complete a post-survey evaluation, that there will be a QR code at the end. We really appreciate feedback. This helps us develop our lectures, different topics that you guys are requesting, and more information that we can make sure that we are meeting your need and getting you the material that you are wanting. And then lastly, at the end of the lecture, there'll be additional QR codes with more information about TEPI that if you want to connect, we encourage checking out some of our other different core projects along with our TEPI email address as well. So before we get into today's topic, I just want to briefly talk a little bit about the Texas Epidemic Public Health Institute, or TEPI. And the whole mission of TEPI, which is the state organization that's housed at UT Houston School of Public Health, is to really keep Texas safe and help build a stronger economy by strengthening its capacity and resilience in Texas communities to respond better to the next infectious disease outbreak. I will be your presenter today. My name is Dr. Kayla Ruch. I have my PhD in epidemiology, which is a focus on infection prevention and control research, education, and implementation. I'm also an infection prevention practitioner. I'm certified in infection control, certified in public health, and a healthcare accreditation. And I have experience both working in acute care facilities here in Texas, long-term and skilled nursing facilities in New York State, and then also acute care facilities in California. And today's learning objectives are just to briefly give you an overview and kind of better understanding of what quality improvement and how to really implement different projects within your facilities. We are going to discuss how to first choose a quality improvement project. Secondly, demonstrate how to collaborate with multiple departments on a quality improvement project. And then lastly, we are going to describe how to establish key improvement indicators or KPIs. So we ask that all questions will be held until the end after our learning activity. And then just again, this lecture is recorded. You will receive a link to the recording within about a week after the lecture, along with the slide deck. And this lecture has been approved for 1 hour continuing education if you hold a CPH certification or if you are a certified infection preventionist and you have your CIC. So let's begin talking about quality improvement. Here's just a quick overview about some of the analysis that we're going to talk about today. We'll talk about each of them in detail. There are many types of quality improvement processes, methodology, and analysis that you can conduct at your organization. And it's really based on what the culture of your organization and what specific project that you aim to implement within your organization when you're kind of deciding what methodology or analysis that you're wanting to perform. So what is quality? We hear that a lot. It's a very trendy, innovative, high metric of quality in healthcare. But when we think about that, what is that exactly? Is it patient outcomes? Is it a focus on readmission rates, length of stays, healthcare associated infections throughout the organization? Does it have to do with surveillance what type of surveillance we should be conducting, and what our surveillance data tells us. Is it our emergency preparedness plans and our surge plans at our organization? So in case of an emergency, we have a set plan in place that is the most efficient, effective way to handle an increase of patients, and while mitigating risks such as low staff members and having access to PPE. Next, we want to think about who is responsible for implementing quality improvement metrics and just overall having quality in their healthcare organization. Is it our clinicians or our bedside providers that are physically providing care to patients, assessing them? Is it our healthcare workers or our allied healthcare workers that are kind of doing ancillary activities, providing more support? And is this important? And the answer to this question is everyone within the organization is responsible for implementing quality control. As we have talked about, infection prevention and control involves making sure you have a safe environment for patients and staff within a healthcare facility, and looking at quality metrics and designing policies and procedures and promoting a culture of safety within an organization directly relates to quality. So how long has quality been around? Well, since 1996, the Institution of Medicine, now known as the National Academy of Medicine, has really started having harder focus on enhancing quality in healthcare across the United States, which is very interesting. Since in infection prevention and control, we started looking at quality and process improvement measures and methodology back in 1960s, when we started to see the MRSA outbreaks that was going throughout the facilities in the United States, that led to much of our surveillance measures and metrics that we started collecting. And these quality initiatives are really aimed to address widespread concerns on inconsistency in healthcare delivery, patient safety, which, as I have mentioned and will continue to mention, infection prevention and control really advocates for patient safety and healthcare safety of our healthcare workers in our facility, and overall effectiveness. The burden of harm conveyed by the collection and impact of all of our healthcare quality programs is staggering. It requires the urgent attention of all stakeholders. This is kind of the call to action of that. It is everyone's responsibility to really address and improve quality and provide quality healthcare within their organization by covering multiple different disciplines and different actions. Two of the big drivers of quality improvement process here in the United States is the Joint Commission, or TJC, and the Centers for Medicare and Medicaid. As many of you know, or you are new to infection prevention and control, these are our two main focus drivers that we use in a lot of our quality improvement projects, to really make sure that we are on track with regulations, recommendations, and it goes into our credentialing and accreditation process within the healthcare facility. So knowing that quality improvement projects is a specific promotion and driver of Joint Commission and CMS, you can really take that information and drive it into your policies and procedures. I know the Joint Commission, or the Joint Commission standards, really require healthcare organizations to have an outline, either infection prevention and control program, which assesses different risks, goals. We report our benchmarks and kind of create different quality improvement projects within our specific realm of within our service line. And as I have said and will continue and always say, that infection prevention professionals' main focus is ensuring safety, and that really involves developing, implementing, monitoring best practices within a healthcare setting. So this is directly relating to looking at the quality that we are creating within our organization and the quality of care that we are providing, identifying gaps, continuously improving our practices by reviewing current and updated standards, recommendations, looking at new science that's coming out of how to combat some of these things, developing new toolkits, along other things, with working with multidisciplinary teams to really address these issues so that we can really drive quality within the organization. And many of the quality things that we look at are, I think I skipped a slide. Let me go back a second. I apologize. Infection prevention, as we've talked in some of our other previous lectures in 104 and 204 as well, of really looking at what do we do in the infection prevention, what data are we collecting, and how can we use that data. Infection preventionists or anyone that is tasked with in developing, running, and maintaining the infection prevention and control program has a lot of different initiatives and core components that really drive quality, such as conducting surveillance activities, that is our current surveillance, that's your following your surveillance, protocols, plans, procedures based on your county and state recommendations. We perform education to both patients and staff about specific communicable diseases, best practices, trying to ensure both safety and efficiency. We engage in adherence to evidence-based practices. That's our current guidelines, our updated modifications. Anytime there is new science, we are kind of the ones pushing for that to be done, conducting it ourselves, and implementing and disseminating that information to our organization. We develop various effective communication methods of talking about how we're transmitting this information, making it clear, concise, using SBAR along with other tools to make sure that everyone is on the same page and they understand the risk and the benefit of what we are trying to do. Then we use external reporting methods. We look at different references of our SEER rates and our SIR rates, along with our community and state impact of communicable diseases, what's on the rise, so that we can properly prepare within our organization to be ready. That goes into our emergency preparedness plans and surge capacity plans of if we are at surge capacity, is there potential service lines that we are shutting down? Are we delaying? Are we changing the layout of negative pressure in our organization? Are we cohorting and are setting up zones to deal with a certain type of infectious patient at that time in our facility? We conduct outbreak investigations. Earlier this year, I gave a lecture on how to conduct an outbreak investigation, and then the follow-up lecture was a contact trace. I encourage everyone to go back and look at that lecture if you haven't attended. And then lastly, that we develop appropriate policies and procedures, specifically our infection prevention control plan, our overall governing policies that affect everyone within our healthcare system, to really reduce transmission rate of infectious pathogens to patient and patient to staff. And as I've mentioned, we use many risk assessments in infection prevention and control programs to really understand what's going on. And those risk assessments are really supported by our surveillance activities of knowing what's going on, or if we're starting to see an increased trend or a downward trend on certain pathogens in our organization, how that can be then going into our policies. If we need to change our policies, change our practices, maybe change a procedure based on this information, we look at our way to develop policies and have plans so that in case if there is a situation, another pandemic per se, or a mass casual event, or a weather event, we are in Texas with flooding and hurricanes and other things, that we are properly prepared to handle those situations when we might not have electricity or water, staff shortage or resource shortages. And then lastly, we're doing all of that to try to identify where we can where and how we can reduce the risk of communicable diseases through different prevention programs such as screening, immunization, education, and management, to ensure that we're not having spread of transmission throughout our organization. And when we look at quality, the first thing that you want to look at is your process improvement. So what what needs to be assessed in your facility to potentially get a better outcome. And as we've mentioned, infection prevention and control programs are in a constant state of process improvement by looking, evaluating, collecting data, having surveillance data, looking at current recommendations, regulations by all our bodies that we look at, CDC, CMS, and others. And usually with our process improvement, there's two different ways that we can start understanding the problem, because if you don't understand the problem, you will not know how to efficiently, effectively address it and improve it. So kind of knowing where you are and what the current state of thing is, understanding where your opportunities for improvements, your gaps or weaknesses, then can lead into improving and strengthening those areas to really get you to that benchmark. So when you first start thinking about what processes that might need improvement, there's two different ways that you can look at your data. And the quick question, TJC is the Joint Commission is one of the accredited bodies, and CMS is the Centers for Medicaid and Medicare. So you can use two different types of data, the quantitative or qualitative. Quantitative is kind of what we think of those hard number data. Those are our specific infection rates, our ratios. They come from our surveillance programs, our mixed database. That could be an internal database or an external database looking at our SEER rates, which is our standard infection ratios that the National Healthcare Safety Network, or NHSN, which is a part of the CDC, set for different healthcare acquired infections, depending on your organization where you should be following. We can also look at medical records to get certain information on our patients and demographics and certain risk factors that they may have. And our quantitative data is usually used to measure benchmarks and thresholds, kind of giving us a driver of, you want to be at 3%, we want to improve by 60%, 30%. It's kind of that overall hard number. Compared to our qualitative data can be very important as well. It's very explorative, and we kind of obtain information in different ways of having interviews both with patients and staff, kind of understanding what's going on. It's eye-opening when you go and interview people to get feedback, to really understand it. There might be a big difference, and hopefully not, that everyone's following policies and procedures. You can do direct observation. We've talked about in previous lectures how when you audit and monitor, doing direct observation, especially in outbreak investigation, when you're trying to put in new control measures, that you are specifically observing, you're talking through, you're asking how the workflow is so that you can understand the complete picture. And then also looking at your written documents, and these can be your policies, your procedures, any health alerts that CDC or the local county or state has put up. And that kind of really helps you drive and provide more information at the organizational and operational context of how you can fix things by kind of understanding the patient flow or procedure flow of what's working, what's not working, how they're doing things, why they're not doing things a certain way according to policy and procedure, or what's working well too in policy and procedure that it is matching identically what we said that we're going to do. So after you determine what type of process improvement data that you want to collect, then the next step is to do strategic planning. And this will really influence the direction of where the department, process, organization is going to go and kind of set up a plan of how we're going to reach our goals, objectives, and benchmark. So we always want to be making sure that we have data-driven, either quantitative or qualitative, both equally great depending on what you're trying to do, and then start planning of, now that we kind of understand and we've explored what's going on, how are we going to address this issue and make improvements. And this needs to be efficient, effective, and mindful of your resource. So your times, your personnel, your materials, and your operational impact and flow. So you could have a wonderful project that is a high need, but because of the time that it's going to take, or if it's going to disrupt operational flow, it's likely to get support and therefore not achieve the goal that you need to do. So that's very important to keep in mind when you are developing these types of things. And then next, after we kind of starting to develop our plan, while we're having that strategic planning meeting, you want to make sure that you are creating multidisciplinary teams that can really help you with the strategic plan. They will have great insight of what the procedure, policy, flow is for the certain initiatives that you are trying to use. You want to at least include at minimum one member of each department at this initiative. So even if they play a small role within this, such as providing supplies, you need to have them in that meeting to make sure that there is not a disruption with your supply chain. That device, if it's rolling out a new device because it's more effective and efficient, that it's within cost and that we can get it, and there's not going to be like a 6 months back lag because the product's on back order. So when you're starting to look at a new product, make sure that you have everyone at that meeting to start talking about it. And at that time, you will be assigned roles and responsibility, usually a team lead, to really kind of assess the project and kind of support and drive it. They will provide technical advice, training, education. They'll help facilitate it, set meetings, set schedules, they'll set agendas. And then collaboratively, you want to discuss timelines, objectives, and benchmarks. So each timeline is based kind of on your project. Each timeline will be unique based on your organizational needs, operation flow, resources, staffing, patient flow. If you're looking at improving patient outcomes for a specific procedure that your facility only does that procedure, maybe once or twice a month, you'll need more time to have a larger sample of looking at how you are doing that procedure, what are good outcomes, bad outcomes, and then how you can address and fix and kind of push those bad outcomes into positive outcomes. And then lastly, you'll set expectations, have clear, consistent communication within the organization of, when you are meeting, who's assigned what, and kind of agree on what the follow-up period is going to be, and who is responsible for coming to the meetings, and then who is responsible for the follow-up initiatives. So now we're going to go into a few of the analysis that you can use. The first one is a failure modes and effective analysis, and this one is a proactive approach that really looks at failures and its effect. So this is kind of the what if X happened, what would the impact be and how severe it would be. For example, say if there was an outbreak of Ebola tomorrow, what would happen? Are we set up and prepared for it? If we had one patient, if we have 10 patients, what that impact's going to be, and if we're not, what's the severity that could potentially happen? Are we going to have staff death? Are we going to have patient death? Are we going to have to shut down the hospital? Are we shutting down service lines? So it's kind of that very broad picture of what could happen, and then trying to create these scenarios and then develop and make sure that we have our policies and procedures in place to handle that, and kind of do walkthroughs of it too. So not only assessing what's in place, but then actually going through and walking through this scenario to see if there's other failures that you need to identify through it. The next one is a gap analysis, and we use this a lot many times, and it's comparing best practices to your current practices. So here's just kind of a template that I've used before. I always look at my first, what area am I specifically looking at? I identify that. Then putting up my standard and guideline. Well, is there a standard? Is it a recommendation? Is it a regulation? Is it a guideline? Is a law? And then what's the source of that? Who's stating that? So your next column. And then the next section, your current status is how compliant are you, or what's your hard metric at that level of that area right now. So then you're kind of rating it. And then the next is the gaps identified. So what is there a gap identified of what your current status and your goal is, and you're below it, then yes, there's probably something that is occurring that you're not reaching that goal or that benchmark that you're going into. So that's kind of when you go into that exploratory phase of like looking at surveillance data. You can use a mix of quantitative and qualitative. Go look at your data, see what's going on for these certain initiatives, and then go interview and directly observe staff to kind of get a pulse on what's going on in the facility so that you know how to develop then an action plan by identifying the gaps of, you know, do you need to do retraining? Do you need to modify policy? Are we out of supplies? Is that certain supplies back ordered? And then you are assigning responsibility. So whose responsibility is it to correct that action, and then have a timeline that it needs to be corrected in X amount of time. And that your timeline will based on, you know, your organization, again, the staffing, and the overall culture in your facility. And here's just another example. The link is for this reference is in the reference section of just kind of a walkthrough on a gap analysis toolkit that you can use. Next is the root cause analysis. We do this a lot in infection prevention, especially after a healthcare associated event. So this is a retrospective look back of kind of your whole process of what's going on. So root cause analysis, usually with healthcare associated infections, involves sitting down with every at least one member of each service line that was directly involved in the patient care, and then looking at, well, what happened. So you first kind of start with your patient related issues. So your patient, it is a female, male, comorbidities, certain risk factors. You're looking at that whole picture. And then you're looking at their environment. Where were they housed? Did they have a central line? Did they have a urinary catheter? Did they go to surgery? Were they on dialysis? What was their environment? Were they in a single room, a multi-room? Did they move around a lot? Did they have a lot of ancillary services such as PT, OT, additional imaging, lab draw? Who was involved in that patient's care? What equipment was used on them that could potentially be a source of transmission, person-related events in our policies and procedures, as well, of, you know, who was involved, was it according to policy, was there gaps, and kind of really interviewing and talking about certain care mechanisms of, you know, looking back at the chart and saying, oh, this was documented, was this done, how did this look, and kind of just talking about the case so that you can identify the root cause of where the gap was, so that you can work to make a change to prevent it from happening to the next person. Next, then, after the root cause, you can use the PDSA model, which is the Plan, Do, Study, Act. So once you have identified a gap, or you can use this after the gap analysis too, of then developing a plan of what's next to try to improve our objectives. And then what are we going to do about it? What type of policies, procedures, are we re-educating? Are we retraining? Are we adding staff? You know, what's going on? And that we can understand what our current practices are going into our study, to the study section. And then what are we going to do about it? How are we going to drive improvement? And this is a very cyclical system, so there's always constant changing. As more information becomes available, you're gathering more information, and then it's influencing how that you modify your next step based on more information gained as well, and to make quicker, better improvements of care to that patient. And then here's just a worksheet. Link is in the references as well, that you can walk through a PDSA of how to look at goals, how to determine objectives, and kind of describing different timelines that you can use. The next one is the strength, weakness, opportunities, threats, or a SWOT analysis. This is really great of starting out with, well, what are the strengths of this specific policy and procedure or protocol that you're looking at modifying. What's going well, essentially, that, there is 90% or higher compliance, it is followed to a T of what we were doing, and then what are weaknesses? What are things that, are a little below par on it that, maybe we follow them sometimes, maybe we have a lower rate of compliance, whatever, and therefore from our weaknesses, where are the opportunities then to move those weaknesses to a strength? Is it re-education? Is it retraining? Is it, having more support? Is it changing products? Is it changing workflow? You're looking at how we can improve. And then lastly, what's our threats? What's our specific barriers that could potentially occur for us not to reach these metrics that we are driving toward? And then the last one is the define, measure, analyze, improve, and control, which is a very popular Six Sigma methodology of first defining your problem, of what you're specifically looking at, defining it, developing your project, then how you're going to measure it. Is that data collection, in what's our trends, our timelines, how you're going to analyze it, where's our goal for improvement, and how are we going to control that, which usually involves monitoring, documentations, re-education, and communication. So now that we've gotten all that out of the way, now we're going to go in through a learning activity that's kind of an example of how to develop an infection prevention quality improvement project. So I ask you all to scan the QR code so that you can follow along and answer. I'm also encouraging everyone to put their answers in the chat to try to make it more interactive. And then once we go through the whole scenario, then we'll open it up for questions. So just a little bit of background before we begin with this specific quality improvement project. We're going to look at catheter-associated infections, or CAUTIs. And as we've talked about in the previous lecture in 105 last year in November, an indwelling catheter is an invasive device. It's used for incontinence, either urinary retention, but it's an internal dwelling catheter compared to our external catheters, such as our condom catheters or our female external catheter as well. These devices have a higher risk of infection and transmitting infection, and they have epidemiology definitions that relate to healthcare-acquired infections that the National Healthcare Safety Network, or NHSN, which is a component of the CDC, defines, that we are required to report, track, and report these up to NHSN. Also, local county and state health departments will sometimes ask for this information to be directly reported to them as well. So our CAUTI criteria is usually when someone has a catheter, urinary catheter, an indwelling urinary catheter for more than 2 days of device being placed, is the main point. So it needs to be in 2 calendar days, not 48 hours. Just for clarification, it doesn't matter if that device gets put in at 11:59 p.m. on today, even though it's just one minute on this day. NHSN deems that as day 1, and then tomorrow would be day 2, and then on day 3, which would be Saturday of 3 days being an indwelling device, that would put them at increased risk of developing a catheter-associated infection, and they are eligible to have a catheter-associated infection CAUTI definition. So our patients need to meet definition, our patients need to have an indwelling catheter for more than 2 consecutive calendar days, and then have one of the following symptoms: either fever, a suprapubic tenderness, which is not related to anything else. If they've just had a very invasive, complicated abdominal surgery and they're still and lower in their colon or small intestine as well, it gets a little bit more difficult of, is that tenderness related to the surgery, or is it related to this infection as well? Urinary urgency, frequency, and painful urination. And then they need to have a culture a urinary culture with over 100,000 CFUs per milliliter in that culture growth, and it can't be more than 2 organisms. If it's 3, it's excluded. So yes, and the mixed flora is not a viable pathogen used according to the National Healthcare Safety Network, or NHSN, and they also exclude anyone that has candida, which is, any yeast. Yeast is a very common pathogen in the urogenital tract, so it can naturally be just in our urine based on the individual. Mold, fungus, and then other parasites too are excluded in there. And this is just kind of a quick workup of that. A patient, kind of the hierarchy of how infections get determined. That first, a patient has identified symptom or asymptomatic. So for this one, we'll use that a patient had a urinary catheter for more than 2 days, and they now have a fever, which is NHSN defines as 100.1 or 100.4 or higher. That's the number that it needs to be. And that then they have a culture growth of greater value or equal to 100,000. And then you want to make sure that they've had their indwelling catheter for more than 2 days. They have symptoms, they don't have symptoms of UTI, and then that's kind of the overall just visual flow of the UT workup. So with that information, now we will start our case study. So if you didn't scan the first QR code, here's another opportunity to please scan the QR code, and we'll go through an example of how developing a quality improvement project specifically on CAUTI reduction. Okay. All right. So in this case study, we have IP Lillian is conducting a 3rd quarter review of healthcare-associated infections. So we're looking at all HAIs, our CLABSIs, which is our central line-associated bloodstream infections, our CAUTIs, our catheter-associated urinary tract infections, our CDIs, which is our C. difficile infections, and then our SSIs, which are surgical site infections. And we're looking at the 4 quarters within the calendar year. So you can see it as quarter 1, quarter 2, and quarter 3. And she's also comparing that information to last year. So you always want to be continuously tracking and also looking back to the last year to see what's working, what's not working, how are you trending. That can help you understand, and this kind of goes into the quantitative surveillance data that we talked about earlier in this lecture, of looking at your data, kind of knowing what's going on, that you realize that there's a potential issue. So this is 2023 and 2024 data right there. So from those metrics on that chart, which HAI metric seems to have an increased trend in 2024? Is it your CLABSIs, your CAUTIs, your CDIs, or your SSIs? And feel free to put your answer in the chat. Great, yes. The answer is B. You see a big increased trend. So next, she noticed that based on this information, a rising trend in catheters throughout the year, and decides to analyze the data to look a little bit further for looking at additional patterns. So now she's breaking down the data even at the unit level. So our first way that we were looking at it in the last slide was at the organizational level, and now we're breaking it down to, well, where have these CAUTIs been? Where, what has been exactly going on? So now we look at our different areas throughout the organization. So we're looking at Q1, Q2, Q3, the months and the locations in the facility. So each number is like 2A, 3B, that's a specific unit within the organization. So that you can see that, in quarter 1, there's 1 CAUTI on 2A, 1 on 3B. In quarter 2, it's 1 on 2A, 1 on 3C, and 1 on 4B. And then 3rd quarter, you see a huge increase from 3 in the previous quarter to 6 now. So we have doubled our CAUTIs in 3rd quarter. which is not great. And then you can see that they're on 2A, 3CC, 2C, 4B, 3B, 4B, and 2A. Okay. So based on that information, we have identified a trend that there is an increase in catheter-associated infections, specifically going into our third quarter, which is very high compared to our second quarter. When we're looking at this issue, what unit or units would we then develop a KPI project for? Is it a unit specific thing, or since that this trend is throughout the organization and there is an organizational problem, do we include everybody? So do we look at specifically 2A, 3CC, 4B, or all the units who have a Foley, which make them at risk of catheter-associated infection? And feel free to put your answer in the chat. So yes, that is correct. You want to make sure that when you are developing a KPI that you're using every unit that is involved in that process, because you want to know what's working and what's not working. So you even want to include the units that are doing really well, because maybe they can be championed, maybe they can cross-train. You can go evaluate how their process is doing versus a unit that is underperforming. So we want to use every unit that has a Foley that puts them at risk for the specific project to be involved in it. So then next, after we have identified this is going to be an organizational wide project, IP Lillian then discusses it with her specific department, and she wants to look and discuss what type of metrics that they should be used. So at the next IP meeting, she's looking at the data, presenting it to the IP team of what specific KPIs or key performance indicators or quality assurance and performance improvement of QAPI is needed to really help address this. Is there a problem? And based on this information, everyone kind of agrees that, yeah, there is a problem, especially that we shot up from 2 CAUTIs in Q1, 3 in Q2, up to 6 in Q3. So then now when she is starting to, she has done the process improvement data looking at it. She's done some surveillance quantitative data of understanding what's going on. Then she wants to have a meeting to discuss and start developing and creating a quality improvement team. Who should she invite to this meeting? Is it all the departments throughout the organization? So every single department? Is it just departments that are involved in the process? Is it only a nursing department, or is it only a microbiology department? And what do we think that the answer is? Yes, as we mentioned, it's B. We want to involve everyone that is affected and put them at risk. So for units that don't have catheter-associated events, it's not good use of their time and energy to come to these meetings. So making sure that you have all the right key stakeholders at the meeting to discuss a multidisciplinary approach, set timelines, give tasks, to really look at your cardiac abstract. So next she schedules a meeting specifically looking at nurses, physicians, microbiology, and central supplies. So from the beginning of who is ordering the catheters, which is our physicians, and placing them, to our nurses who are handling the catheters, to our microbiology to make sure that, what has changed, that, now we have more of these cultures that are growing. Is there something that has changed on micro end? Is there a certain pathogen that we're seeing more common on these catheter-associated events? And then our central supplies of, have we switched vendors? Has there been a change? That's always a good conversation to have. What are we using? Are we using it effective? Was it recalled? Could this potentially be a recall? And that's why we have these issues for these infections. So really getting everyone, at least one member from every multidisciplinary team, to really discuss and promote these efforts in quality improvement. Next, she's going to then collaborate across departments and discuss potential issues. So she's going to go into this meeting being very open, supportive, and present the facts to the team. So not cast blame, not cast judgment of, you didn't do this. It was, I was exploring the data. This is what the data shows me. This is what we're seeing at the organization. Truly facts, not speculation, being very receptive, kind of getting a pulse of what is going on. And we want to then talk about specific areas of owning the process. So for nurses, we're going to talk specifically about CAUTI prevention, auditing, bundle insertion practices, and audit those to see what's going on. Physicians talking about with them their review and justification. Are these catheter-associated events because these catheters are in for weeks at times because the physicians are reluctant to take them out? Is biology of looking at pathogen surveillance and culture and practices, has something changed? Are we seeing an uptake? Did we switch medias? Did we switch platforms? Are these true positives? And then lastly, central supplies of like looking at, have we changed our Foley catheters? Have we changed our peri-care material, our CHG wipes, our microbiology, urine culture tubes, etc. So it is important to discuss all these components to increase the CAUTI rate because you need to look at it. Is it because you need to understand the issue before an effective solution can be developed? Infection prevention, B, infection prevention and control issues are complicated. C, only one approach is needed. Or D, it's not needed and collaborative meetings are a waste of time. Yes, so the correct answer is A. You always want to make sure that you have everyone on board so you understand what is going on, that when you are developing metrics and what you are planning to do is going to be efficient, effective, and mindful of all our resources, including our personnel's time. So after that, we will have a complete picture of kind of what's going on, and then we're kind of going to the next step further. So this is now going into one of those RCAs, or those root cause analysis, to kind of understand, in our most recent catheter-associated events, what retrospective information came alight in that was a potential cause. And after we were talking about a certain case, we found that from what the nurses were telling us, that there is an influx of new graduate nurses beginning to work at the facility. So this could be potentially that since they're new, maybe they don't feel as comfortable, maybe they need some more mentorship. Let's talk about re-education. Let's provide them support so they're not feeling as nervous. Or that they don't feel like this is punitive or that they've done something wrong, to really emulate best practices. We then look at our physicians, and our physicians are forgetting to remove Foleys. I've seen that multiple times, that an order for a Foley will get placed and then it gets forgotten. And then it kind of gets left out of the notes, and then people assume that it is no longer in place. And then when you physically go look at the patient, you look on the bedside, that you realize, oh no, they do have a catheter still. And then lastly, you're going to look at the central supplies and microbiology of like looking at specifically their culturing tubes. Has there been a change? And do we have the preservative tablets that are in the cultures? Have we switched vendors? And those tablets within the urinary cultures are prevent biofilm from forming and really increase the integrity of the sample. So you're not having overgrowth of the urine within the tube itself, and that you're having very good cultures done. And then when you are talking with everyone about specific different metrics that they are involved in and looking at, there's in the quality improvement, you always want to use the SMART criteria, which is be specific, measurable, obtainable, relevant, and timely. So making sure that this is a specific, measurable thing that you're wanting to do, it's realistic or attainable, it's relevant, since that there is it's impacting the organization and many people in the organization, and timely, that you're assessing this in a timely manner. So what would be a smart metric for the number of CAUTI reductions? So we have now looked at the data in that we see an increase of catheter-associated events. Now we're wanting to reduce them. What would be an appropriate metric to kind of goal to reduce in quarter 4? Are we saying we're having 100% reduction, so we're moving from 6 catheter-associated events down to 0? Are we wanting a 30 to 50% reduction, so moving to that 3 or 4, which is in line with what our quarter 2 was before? Are we wanting a 75% reduction, moving then down to 2, or 10%, or just a 10% reduction, moving down to 5 instead of 6? What do you think would be an appropriate metric to try to gauge for a goal for quarter 4? Yes, that's great. Answer B. So yes, the appropriate metric or realistic, reliable, obtainable metric would be a reduction in 30 to 50% reduction, since each quarter is about 3 months time. So we're wanting our goals to go from 6 CAUTIs down to 3 to 4 CAUTIs. And then when we are developing this key performance indicator product or QAPI, what type of approach is needed? So now we have our metrics set. Are we going to take a single approach, so only look at one of the facets? Are we going to look at 2 different departments? Are we going to look at all the departments and make it multifaceted? Or are we just going to try everything and see what sticks? Try 10 different things and hopefully 1 or 2 work. What would be the correct answer? Yes, C. You want to take a multifaceted approach. Especially when you are wanting to change culture, practices, and procedures within the organizational level, you need to look at this type of shift as very collaborative with a bunch of people to really help drive it. And you'll look at specific different metrics, as we've talked about with nursing, physicians, and microbiology and central supplies. So for nursing, our thing that we identified from our root cause analysis is training and re-education. So you'll tap into your nursing education team or go provide nurses with new education of pushing out education that can involve watching, auditing, monitoring, pushing out the policy procedure of insertion practice. It's great to have, if you can develop 1-page handouts that are like quick sheets for them to reference with focus on unit training that have the highest incidence. So the ones that are, have had catheter-associated events in high numbers or the highest number, you want to start with them first and then go down and push out that same education to even the units that are doing well, because there's always opportunity to do better. And then auditing, making sure that you look at your Foley utilization, so looking at how many Foleys that you have within your organization based on your census or how many people are admitted within your facility to make sure that the number is reasonable. Which, for an example, if you are a 250-bed hospital, if you have 200 Foleys at your facility, that is not reasonable. So really kind of auditing to see what your utilization is and try to drive lower utilization, since removing and not inserting Foley catheters. And this is just like an example of a handout that you could create of, just high touch points, what the infection risk, what they can do, hand hygiene, placement, making sure that the Foley is connected using their stat lock. There's no loops, there's no tubes, it's below their bladder, so you don't get backflow into the urine, it's hanging appropriately. Just a quick guide that, really sends your message and that your healthcare provider staff can use very quickly. And then here is a audit tool that the link is in the references that you can look at specifically doing catheter audits. Joint Commission has some, CDC has some, different local and state health departments will have these free tools. Here is one from the California Department of Health, a great tool that they have that is freely available to how to track and look at your catheter utilization. Next, as I just mentioned, When you're auditing it, you want to look for what? The appropriateness, duration, system flow, or D, all the above. So when you're auditing the catheter, how it looks, do you want to make sure that, it's appropriately inserted, how long it's been in there, making sure that the bag is below the bladder so you're not getting backflow? Yes, the answer is D. Next, after you roll out nursing education, you start seeing urinary catheter utilization decrease. And so instead of seeing, 50 Foleys, now maybe you see 40 Foleys. The next initiative, you'll start looking at the orders from the physician. So you want to meet with the CMO, which is the Chief Medical Officer, to discuss collaboration, to tap into your physician network. You can also work with IT to build reminders or order sets in electronic medical records or EMRs to DC or remind people, hey, this Foley's been in for X amount of days, it needs review. And the current best practice is switching to a nurse-driven Foley removal protocol that, if it meets this criteria, usually the Houdini criteria, that then they are eligible to remove that Foley without a physician's order. And that's all supported by IDSA, SHEA, CDC, APIC, and other things, a best practices approach for Foley removal. So after you meet with the CMO and you build in different things into the EMR, and you convert the organization to a nurse-driven Foley remover catheter, which might take a while, to vet a policy procedure, to understand the culture, if this is something that's doable, to get that developed, that will take some time. But here's just our numbers of Foleys that we started to see before physician engagement, after physician engagement, which is great. So you start to see, a decrease after then engagement with the EMR order set, and then complete almost over 50% reduction after having physician engagement, EMR order set, and then switching over to a nurse-driven Foley removal protocol. So from what we just talked about, which approach produced the best outcome? Was it using the single prong approach, so just physician engagement with EMR engagement, and nurse-driven protocol removal, or all approaches produce the same outcome? And yes, the correct answer is C. Lastly, then we'll look at central supplies and work with vendors to look at specific materials and making sure changes in our Foley catheters, what Foley catheters that you have in your organization, are they impregnated with that silver antimicrobial end that far than some of the other vendors do that have shown clinical evidence of reducing infection risk? Look at your pericare materials and your CH2 wipes, and then remove old inventory from units within the hospital. So making sure that they don't have old stock that maybe if you've switched vendors or switched products at nursing units are not hoarding, to keep that just in case, but that you're actually physically auditing their supplies on their unit to make sure that they have what they're supposed to be having. And then talking with microbiology on urine collection and kind of collaborating with them of making sure that you have the right tube, the right collection, room temperature parameters, and that the units themselves know how to properly collect and transport and send down the tube for collection. So after IP Lillian meets with multiple different engaged people, then she confirms that nursing education is being monitored, physician engagement, central supplies has been appropriate, and then microbiology is not seeing contamination with urinary specimens and cultures. And so we start seeing our numbers shift after we have met with all 4 departments. So now in our next quarter, we see only, you see the previous data from quarter 1, quarter 2, and quarter 3, and then for quarter 4, October, November, and December, you see that we have switched down for the whole month as 4 catheter-associated events, so that's great that we started trending down. And what percent of reduction was that? So from what is the percent of reduction from the 3rd quarter to the 4th quarter? Is it about 20%, 25%, 30%, 33%? And yes, the correct answer is D, 33%. And lastly, by creating a smart KPI and using multi-faceted approach, quality improvement process was achieved with CAUTI prevention, yes or no? So after we did all this work, did we get to our goal of having our metric obtained within the timeline that we wanted to? Yes, the correct answer is yes. So here's your answers. And as we wrapped up, quality improvement involves interdisciplinary, multidisciplinary implement change. It focuses on creating better culture of safety and quality for both patients and healthcare providers within your facility. It is a continuous process, always focusing on patient safety outcomes, customer satisfaction, and service of quality. So we'd like to thank you for coming to today's lecture. You can connect with us. Here's our email. Feel free to send us any type of emails with additional questions, comments, general inquiries. Here's our QR code to our general Texas infection, our TEPI webpage. And then our lastly for announcements, this is a QR code that I would kindly ask everyone to fill out the post-survey evaluation. Provide us feedback of how we can improve, what additional topics that you would like to see in year 3. If you complete this survey, you will be entered into win potential TEPI merchandise that we will mail out to you as a thank you for completing the survey. Within about a month, we will be sending out an infection prevention control impact survey that really talks about the whole year 2 of this lecture series. We are now at the close of it. We've done 10 lectures on different infection prevention and control topics this year. And if you have not come to any of them or just some of them, they are all recorded on our TEPI YouTube channel. We encourage you to go watch. Some of them have been approved for continuing education, either your CIC or your CPH. And we ask that you watch the lecture, do the learning activity, and then complete the post-survey, post-evaluation form, and then an email certificate will be sent to you with your hours of continuing education. And now we'll just open it up for general questions. I know we're a little over, but I just want to thank you all for coming. If this is the first time that you've come to a TEPI lecture, if you've come throughout the whole series, just thank you. And please let me know how we can help support you.
Okay, there is one question asking, how many months do you give the improvements interventions before evaluating them?
Sorry, Susie, can you repeat that? My whole screen went black and now just regenerated.
Yes, of course.
Yes, of course.
It's how many months do you give the improvements or interventions before evaluating them?
Well, that's an excellent question. So it depends on what type of improvement project that you're doing, but you want to do continuous evaluation during the process. You want to, not do hard analysis, but, kind of touch in to make sure that what you are recommending is effective and efficient. So you should start seeing little improvement as you go along. If you change a process or if you're doing re-education and then within like a week or 2 or maybe 4 weeks that you start seeing like a high trend in like another issue, that's kind of letting you know that something, the process that you've changed has side effects and maybe not things that you accounted for. So you want to look at different timelines, but also be looking at it at the same time. Quarters are always good. 3-month intervals, since we do a lot of the fiscal calendar year and we have a lot of metrics that are report monthly and then also quarterly. So to be in line with the organization doing Q1 through Q4, but then also depending on if this is a certain type of initiative, giving yourself like a couple quarters for it. For surgical site infection, that will sometimes take a couple quarters or potentially a year, depending on how many surgeries that you're doing with that specific thing, or if you're looking at a very specific low patient population, such as that you only have 10 patients that have this pathogen and you're wanting to have better outcome measures for that patient, you'll have to then wait for, your sample size of that to be high enough to really evaluate that it's been effective.
Those were all the questions.
Okay, great. Well, thank you all. Like I said, this will be recorded. An email to the link in the recording will be sent to you in about a week's time or so, along with the slide decks. These lectures have been approved for continuing education for a CIC or a CPH. And then lastly, we ask you to please complete the post-module evaluation. Here's the QR code. You'll also have access to the QR code when you get the slide deck within a week as well. And thank you all for attending, and I look forward to presenting more material in 2025. Thank you.